Hi everyone, my name is Keabetsoe Hlanze, and today I will be talking to you about sickle cell disease. Now, just a revision of our genetics. It is an autosomal recessive genetic disease. Therefore, both parents need to be carriers in order for the child to be affected. And if both parents are carriers, there is a 25% chance of inheritance. For the purposes of today's talk, we will be talking about the homozygous sickle cell disease, the HBSS variant. Now, when looking at the pathophysiology, at the molecular level, there is a point mutation in chromosome 11, and this results in a differing genetic sequence, which produces a different amino acid messenger RNA, and hence alters the protein which is produced. The beta globin chain is the protein which is affected, and this then produces valine as the protein which is quite hydrophobic compared to glutamate, which is very hydrophilic in nature, and this then contributes to the problems seen in the disease. Now, when looking at our red blood cells, we have a biconcave red blood cell, and in the red blood cell are many of these hemoglobin protein molecules comprised of your 2 alpha and 2 beta chains, and within each chain is a heme ion group that then carries the oxygen around the body. Now, when looking at the pathophysiology, when the red blood cell is oxygenated, there is no problem. The red blood cell has a normal appearance. The problem arises when there is a reduced amount of oxygen binding to the red blood cell. So you have an event which causes deoxygenation and causes the hemoglobin to become sticky and to polymerize, which then deforms the red blood cell, resulting in sickling in various parts of the body. So when looking at the diagram, at the top you have your normal hemoglobin, globular in appearance that has your 2 alpha and your 2 beta chains. And when you have that deoxygenation, there is this almost type of Lego appearance where the hemoglobin molecules clump up and stick to one another and cause deformation of the red blood cell. Now, for the first 6 months of life, infants may not manifest features of sickle cell disease due to the larger proportion of fetal hemoglobin which is present. And remember, fetal hemoglobin has 2 alpha and 2 gamma chains. Now we look at things which cause episodes of sickling. So these will essentially be things which cause a rightward shift in our oxygen hemoglobin dissociation curve. So these are things like acidosis, increased CO2, high temperature, or a high 2,3-DPG. So essentially conditions which toddlers would come in for, such as fevers due to upper respiratory tract infections or lower respiratory tract infections or viral gastroenteritis, have the potential to produce a sickling episode. Now we look at the effects on the red blood cell. So it does cause membrane damage. So essentially the cells can only deform and reshape a finite number of times, and they will then eventually maintain the sickled shape and won't return to the round biconcave structure. Damage causes release of membrane particles which have been linked to increased endothelial adhesivity. Dehydration. So those polymerized Lego fibers interact with the red blood cell membrane and affect the transport systems, leading to dehydration of the red blood cell. And dehydration also increases the concentration of the HBS, leading to even more polymerization. Moving on from the red blood cell to the systemic effects, there are 2 major pathways which sickle cell disease causes damage, and this is either through hemolysis or through vascular occlusion. So because of the sickling and the damage to the red blood cell membrane, cells undergo premature hemolysis. Intravascular hemolysis takes place and leads to an elevation in biomarkers like LDH. Extravascular hemolysis occurs in the macrophages of the reticuloendothelial systems like the spleen, liver, and bone marrow. Regarding vascular occlusion, was previously thought to occur because of the sticky, inflexible hemoglobin molecule, but new evidence has since come out to say that it occurs due to a complex interaction between the sickle cell and its interaction with the vascular endothelium, resulting in endothelial damage, vasoconstriction and inflammation, and subsequent trapping of denser cells. This is illustrated beautifully in the diagram on the screen. So the picture in panel A on the left shows adhesion of the sickle cells to the vascular endothelium in the post-capillary venules. And the second picture, picture B on the right, illustrates subsequent trapping of denser cells in the partially obstructed venules, followed by retrograde obstruction. It used to be thought that vessel obstruction can only occur in small capillaries, but studies in animal models have shown that larger vessels may also be affected. Now we're just going to discuss a few of these sickle cell emergencies. There is a broad range and there's quite a large number of emergencies that may occur, but for the purposes of this talk and for keeping it brief, I have selected 5 which stood out to me, which I will be discussing. But like I said, do please read up on the other emergencies. The first one we're going to be talking about is the sickle cell pain crisis. So this occurs as a result of ischemic tissue damage due to vaso-occlusion of the sickle cells. Triggers include dehydration, acidosis, and sepsis. And areas of pain include the back, chest, abdomen, and extremities. There are no lab tests that can support it, so it is a diagnosis of exclusion. And even though there are no lab tests required, there still should be imaging and tests which are done to rule out other life-threatening causes of pain. Now, in terms of the management, it is a multimodal. So things like paracetamol, NSAIDs, a short course due to the long-term effect of renal impairment, ketamine, which may be used as an opioid-sparing drug. Regarding the use of oxygen, it has been shown to cause bone marrow suppression and increase transfusion requirements. So as long as the saturation of the patient is more than 92%, there is no need to give supplemental oxygen. Same applies to the use of fluids. Only if the patient is hypovolemic do we need to give them additional fluids. Now, to give a transfusion or to not give a transfusion, that is the ultimate question. You might be wondering, patients with sickle cell disease tend to have this chronic anemia in the background. You might be worried about hemolysis, which occurs. We want to increase the oxygen carrying capacity. But the answer is no. Transfusions may actually lead to increased viscosity of the blood and lead to more vaso-occlusive episodes and worsening of the pain. Remembering that diagram I showed earlier that there would be that trapping of the denser cells. So if there is no acute indication for a transfusion, there is no need to give it. The next one that we'll be talking about is the aplastic crisis. So this is an acute drop in the hemoglobin due to a sudden arrest of erythropoiesis. It is usually associated with an illness, so patients may present with this prodrome of fever, coughing, malaise, and myalgia. The hemoglobin will be well below the baseline level of the patient. It is commonly caused by parvovirus. Other organisms that have been implicated include Streptococcus pneumoniae, Salmonella, and Epstein-Barr virus. Clinically, it may be associated with a large spleen. Now, regarding the investigations, you'd want to do a full septic workup. This includes, but is not limited to, your full blood count, CRP, blood culture, urine culture, and chest x-ray, reticulocyte count, which will usually be less than 1%, and serology for parvovirus B19. In terms of the management, these are the patients that require a red blood cell transfusion. Antibiotics is febrile, the third generation cephalosporin, to cover for those encapsulated gram-negatives, and intravenous and oral intake to a total of maintenance fluids. The next one we'll be talking about is acute chest syndrome. So this is a major cause of mortality, has about a 10% mortality rate from acute chest syndrome. And this is defined as a new infiltrate on chest x-ray with respiratory symptoms. And these symptoms include chest pain, dyspnea, hypoxia, or even coughing. And the etiology varies from infective in origin to infarcted lung tissue or fat embolism from infarcted bone. So essentially, you'll have this hypoxia that promotes erythrocyte sickling. The sickling then occurs in the lungs and impairs the pulmonary microvasculature. This then worsens pulmonary function. Because your pulmonary function is not good, you have desaturation of systemic blood, then leading to hypoxia, and so you have this vicious cycle. In terms of the investigations that can be done, x-rays, but this should not delay treatment, point of care ultrasound to assess any changes in the lungs. So there was a small study that included about 20 patients that were admitted for vaso-occlusive episodes that were being monitored for symptoms of acute chest syndrome. So it was found that ultrasound detected changes a day earlier compared to findings noted on chest x-ray. A CT can be done at clinically relevant blood and sputum cultures, as well as a type and screen. A patient with sickle cell disease with isolated chest pain and no other symptoms may be safely managed as an acute pain crisis, but if there is the presence of even one other respiratory symptoms, they should be managed as an acute chest syndrome until proven otherwise. In terms of the management of an acute chest syndrome, here we do give supplemental oxygen in the form of BiPAP or high-flow nasal cannula, antibiotics again to cover for those organisms, as well as azithromycin on top of your ceftriaxone to cover for atypicals, blood transfusions, which we will talk about in the next slide. So there is no real high-quality evidence to support this, but due to the pathophysiology of the disease, like we mentioned, that vicious spiral and the hypoxia, and we want to increase oxygen carrying capacity, we do use it in this context. Physiotherapy may be used for incentive spirometry to avoid atelectasis, and importantly, analgesia. So regarding the two types of transfusion, there's the simple transfusion, where a patient might be mildly anemic and not acutely ill with an HB of less than 7, or a patient might be severely anemic and severely ill with an HB of less than 5. Here, we use a simple blood transfusion, and our goal would be to transfuse to an HB of 10 to 11. Exchange transfusion, this you would more use if the patient has evolving multi-organ failure, or failure to improve despite a simple transfusion, or rapidly progressing lung involvement, so changes which occur over a period of days. And here the transfusion target is about 10 milligrams per deciliter. So there are no trials to prove this, but it is believed that transfusing to a higher HB increases viscosity and leads to increased risk of sickling and complications thereof. So therefore, if a simple transfusion results in an HB of more than 12, they do advise for a therapeutic phlebotomy. Exchange transfusion allows for a rapid and dramatic reduction in the amount of sickled hemoglobin without increasing viscosity. Moving on to our next emergency, which is our splenic sequestration syndrome. So this occurs when the red blood cells become captured and pool within the spleen, and along with it, you have a large amount of blood volume that can be stored in the spleen, resulting in hypovolemic shock. So this is characterized by a drop in hemoglobin, usually 2 below the normal, and commonly occurs in children aged between 6 months to 2 years. I found this interesting article, which was done in Tunisia about 2 years ago, that looked at the predictive factors of splenic sequestration crisis among 423 pediatric patients with sickle cell disease. So it was a multivariate analysis, and they identified 4 baseline risk factors for the initial episode of splenic sequestration. And those 4 risk factors were: 1, age of less than 24 months at onset of symptoms; 2, chronic pallor as a sign; 3, spleen size of more than 3 centimeters; and 4, an absolute reticulocyte count of more than 300,000 per micromoles. Now, when looking at the investigations that may be done, so it would be full blood count and a reticulocyte count. The HB will show a drop with a persistent reticulocytosis, and the FBC will show a thrombocytopenia. Regarding the management here, you might want to be a little bit more cautious. So your transfusion target would be about 5 to 6. You do not want to increase it to by more than 3, because it has been shown it has been shown that with an increasing circulating volume, it is proposed that it will promote a release of those trapped pooled red blood cells in the spleen, result in a so-called autotransfusion, and therefore increasing the risk of viscosity and leading to more sickling. You may also give active fluids for resuscitation for hypovolemia while awaiting the blood transfusion, IV antibiotics if the patient has features of sepsis, and again our go-to will be the 3rd generation cephalosporin. Last but certainly not least is priapism. So this is a prolonged painful erection not associated with sexual desire or stimulation, and occurs as a result of obstructed venous flow, often happens in the adolescent years. 2 subtypes is your stuttering episodes. So these last for about 2 hours but resolve by hour number 4, and these usually may precede a severe episode. These tend to get better by themselves until they don't anymore. You have your severe episode that lasts 4 hours, and these, if untreated, can result in long-term adverse effects such as impotence. There are 2 types of priapism. There is one, the low-flow anoxic or ischemic priapism. This is the urological emergency, and this is what we'll see in patients with sickle cell disease. So this is related to an impairment of contraction of the cavernosal smooth muscle. The other subtype is also known as the non-ischemic priapism, or the high flow or congenital priapism, and this is usually due to injury of the cavernosal artery. Now, in terms of the investigations, you can do a blood gas from the aspirate of the priapism, your full blood count to look for other causes if the patient is not known to be homozygous for sickle cell disease, and you'd be looking for anemia, leukemia, or platelet abnormalities. Your peripheral blood smear might confirm your diagnosis of sickle cell disease, and your Doppler ultrasound that can be used to differentiate between high flow and low flow priapism. Have attached a table that shows gases of blood aspirated from the corpus cavernosa of patients with priapism, just showing the difference in the values that you would expect to differentiate between ischemic and non-ischemic priapism. Now, in terms of the management, hydration, as well as adequate analgesia. Systemic analgesia might not be helpful, so a penile block may be performed using anatomical landmarks or maybe ultrasound guided. Remember, when using lignocaine, it will be lignocaine without adrenaline. Now, in terms of the treatment, you can start by first trying to aspirate the corpus cavernosum with a 20 ml syringe, and you can do it from one side as there is a communication of blood flow between the two sides. Failing which, if that still does not result in detumescence, you can then proceed to a phenylephrine injection or washout. Remember, importantly, areas to avoid is 6 o'clock as well as 10 o'clock. Preferred area, 12 o'clock, apologies. Preferred areas might be at 10 o'clock or at 2 o'clock for aspiration. Now that we've done emergencies, we want to look at long-term management of patients with sickle cell disease. So agents like hydroxyurea, so these work by causing a shift in genetic expression, this increased production of fetal hemoglobin, which doesn't have that bothersome beta globin chain. Prophylactic penicillin for all children below the age of 5. So you would give 125 milligrams 12 hourly before age 3. And then from age 3, the dose is then changed to 250 milligrams every 12 hours. The decision on whether to continue after age 5 is taken on a case-by-case basis. Vaccination against encapsulated organisms. So this would be for strep pneumo, Neisseria meningitidis, and Haemophilus influenza type B. They should also get seasonal influenza vaccine. And the cure for sickle cell disease is a stem cell transplantation. That concludes our talk. Have attached references for your perusal. Thank you for your time.